All right, good afternoon. We're just going to give a minute for everybody to get into today's session. Welcome, everyone. And I will get started with some introductions here. Welcome. We're going to start in just a moment. All right. Good afternoon, everyone. I'm Melanie Escher with the Arizona Telemedicine Program in the Southwest Telehealth Resource Center. Welcome to today's program. So as you joined us today, just some tips and notes. Your phone or your computer microphone were muted. Time's going to be reserved at the end for questions. Please go ahead and use that chat function to put your questions in there, and I will read them when we're done. There will be a post-webinar evaluation that will populate in a screen when we're done. I will also send the URL in a thank you email to everybody that has attended today, so you don't need to worry about writing it down. The webinar is being recorded and it will be posted on our website later. So the outcome objectives, accreditation statement for continuing medical education credits. This was sent out to everybody prior. I won't read through the whole thing. And we use a system with the university to get your CMEs. I will have all that information in my thank you email as well. So you don't need to worry about it right now. And the attendance code will be found in that evaluation. We have our standard disclaimer. You can read that. And again, please check our website for upcoming webinars and events. This month, we've got 5 different webinars going on over the next 3 weeks. So please go ahead and visit that. That URL will be in my thank you email as well, and you'll be able to sign up for our upcoming events. And again, your opinion is valuable to us, so please go ahead and fill in that evaluation. Give us some ideas of other topics that you might be interested in. We do look at those evaluations, and that's how we come up with some of our programs. So today we're going to be talking about telerehabilitation. We've got RF Smiley, we've got Patricia Rocco, and we've got Joseph Finkelstein, who is our new director of the Arizona Telemedicine Program. We're going to go ahead and start off with Patricia today. My next slide. And Patricia?
Hello, everyone. I'm Patricia. I'm a physical therapist, and I'm going to talk a little bit about cancer telerehabilitation. You can go next. So we know that cancer is a worldwide public health problem and is the second leading cause of death in the United States. In the treatments for cancer, such as surgery, chemotherapy, radiation, is all those treatments can result in psychological and physiological sequelae and can affect the treatment completion and the ability to function and perform essential daily activities and quality of life. So we know that physical activity is very important and is an essential component of cancer rehabilitation. And it reduces several things like a burden of specific cancer, including benefits related to physical function, quality of life, and cancer-related fatigue. So the American College of Sports of Medicine, they concluded that the exercise training is safe during and after cancer treatments and improves quality of life in several groups of cancer. Unfortunately, many patients do not have access to all the cancer rehabilitation therapy due to problems related to social economics, transportation, and several other factors that impact the treatment like work, costs, and time. So why telerehabilitation is very important? Because with the remote access and the physical exercises, we know that we can promote benefits that can overcome this burden, such as enhancing patient access, reducing logistical burdens, and facilitating continuous monitoring. So our group did 2 studies that I'm going over with you today. The first one is telemedicine applications for cancer rehabilitation, a scoping review. We included 21 studies in this review. Can go next. And what was the type and stage of cancer of these studies that we found? It was multiple types of cancer, since stage 1 to 3A, breast cancer, head and neck cancer, leukemia, lung cancer, and different types of cancer. Can go to the next one. So what technology was used in this study? So those papers included various technologies. So most studies include web-based system to facilitate patient and provider interactions. Mobile apps were also used. Phone call or SMS texting message was used for 43% of the studies, and other medical devices were also integrated into 24% of the studies, like pulse oximeters, pedometers, heart rate monitor watches. So what was the exercise program for those studies that we found? So most were physical rehabilitation programs that were self-directed, home-based, tailored exercise program where participants follow individualized exercise plan independently. So the web system guide programs accounted for 24% of the studies, using platforms to provide real-time or asynchronous guidance. Most of the exercise programs were home-based, enabling patients to perform their routines in a familiar environment. And the type of exercise were predominantly aerobic exercise, resistance, and flexibility exercises. So with the study, we saw some positive outcomes from telerehabilitation for cancer, as improvement, functional capacity, cognitive function, quality of life, fatigue, physical well-being, emotional well-being, anxiety, reduced pain in hospital length of stay, and there are positive effects also on feasibility, acceptability, and cost effectiveness were also noted. We also see some research indicators that exercise is advantageous before, during, and after cancer treatment and is applicable to all types of cancer. So engaging into moderate to vigorous exercise is particularly effective for enhancing physical function and alleviate cancer-related impairments. So supervised exercise programs have been shown to provide greater benefits than unsupervised ones, with serious adverse events being rare. We have another study from our group. You can go next. So this was a telemedicine supported exercise intervention for hematopoietic stem cell transplantation, another scoping review. We included 10 studies on this review. Can go next. What about the technology for this review? So phone calls and medical devices were predominant the technology used on those studies, 80% and 70% respectively. And video conferencing was reported in 4 of the 10 studies, and fewer studies reported web-based systems, like 20%, mobile apps 10%, or SMS 10% of the studies. So various medical devices were also used for these studies in this review, including smartwatches, heart rate monitors, and gait sensors. What about the exercise program that they used? So aerobic exercise was the most common modality, including in 80% of the studies. Resistance exercise were also implemented in 50%. Flexibility and other exercises such as mindfulness-based stress management, balance training, and also appeared in a few studies. And the most frequently reported session length was 30 minutes for those patients. So in conclusion of this study, although the number of 10 10 studies included was limited, they suggest that telemedicine modalities ranging for telephone-based consultations or video conferencing and wearable devices can effectively support exercise program for hematopoietic stem cell transplantation patients before, during, and after transplantation. We can also see some benefits for the patients that exercise, improving also functional capacity, enhanced VO2 peak, 6 minutes walking test performance, hand grip strength, 30 seconds sit to stand test scores, and better quality of life outcomes. Thank you.
Dr. Finkelstein, you're ready to go.
Hello, everyone. My goal today is to share our experience in assessing clinical impact of telerehabilitation in two illustrative use cases. First, I would like to acknowledge generous funding from multiple agencies, particularly NHLBI, HRQ, and DoD. We will focus on one use case, which is multiple sclerosis, and another is COPD. So as we learned from previous presentations, there's a different modalities in using telemedicine to deliver rehabilitation interventions, and they can be grouped along four major domains. One is live video conferencing, synchronous interaction, another is store and forward asynchronous. There's the remote patient monitoring, which allows to monitor vital signs, and mobile health allows intervention which support mobility. All of these modalities have advantages and disadvantages. Of course, live video conferencing is very instrumental in direct observation of patients at home. However, it would be very difficult to scale it to the extent that it's cost effective and affordable. Storing forward may be more available, however, it lacks supervision. The current trend is to consider hybrid interventions where advantages of all these modalities are used together. And I'm going to discuss with you our experience with this hybrid model. We used home automated telemanagement system, which supports patient self-care plans and facilitates patient-provider communication and multi-component chronic disease management. Technically, it comprises a patient unit and clinician unit. They are both any internet-enabled terminal would serve as a patient or clinician unit, and there is a decision support which analyzes communication between patient and providers, patient performance, and supports individualized treatment plans. From information flow, it allows to implement a team of rehab management comprising, for example, physical therapists, occupational therapists, and provider, where physical therapist is responsible for reviewing and responding to alerts, if necessary, forwarding it to physician. So the first use case we wanted to share with you is physical rehabilitation in multiple sclerosis. Multiple sclerosis requires lifelong rehabilitation measures together with continuous medication treatment, and physical exercise was shown to have a positive impact on patients' quality of life. And interactive web-based management system may facilitate patient adherence to rehabilitation plans. Ideally, comprehensive telecare in patient with MS should include a variety of components which are listed on these slides. In our initial pilot, the goal was to assess the feasibility and acceptance of this hybrid rehabilitation model for a MS patient participating in a structured exercise program. Patients were assessed in person and they underwent comprehensive physical therapy assessment where potential limitation in mobility, muscle weakness, and other components of assessment were carried out in person, And then physical therapists used a virtual prescription pad to prescribe individualized exercise tailored to personal assessment and profile of these patients. The physical therapist also set up patient tailored alerts, which allowed to monitor patient performance on daily basis. And the alerts are reviewed daily, and if necessary, patients is contacted and helped to continue with the program. Patients received very simple, easy interface, which allows them go exercise by exercise. They were guided in performance of each exercise and generating their exercise log. To support their aerobic exercise, they received portable bikes, which also were internet connected and allow to enhance patient engagement by using, in this case, 2D virtual scenery and the exert gaming. Well, they also use interactive resistance chair to support resistant exercise, in addition to other therapeutic exercise prescribed by therapists. This was assessed in using quasi-experimental pre-post design. Our results showed that after 4 weeks of engaging in this program, there was a significant improvement in time 25-foot walk, in 6-minute walk, and also Berg balance scale showed improvement in balance. So overall, we found that there was a significant improvement in patients' exercise capacity, mobility, and balance. So we concluded that telehealth can improve access to an integration of care for MS patients, and telehealth tools may have significant impact on promoting better access to rehabilitation in patients with neurodegenerative diseases. The second use case I would like to share with you is pulmonary rehabilitation. This was a study funded by an HLBI. The impetus to this study was the fact that only 2 to 9% of COPD patients have access to pulmonary rehabilitation after hospitalization. There's multiple barriers which results in this limited access. And the goal of the study was to use telehealth to address systematically all barriers to pulmonary rehabilitation, particularly for patients who were admitted with COPD exacerbations to emergency department or were hospitalized. And this was a multi-component system integrated approach where intervention was on healthcare level, on provider or on patient level, on healthcare level. There was clinical decision support in electronic medical record, which allows to generate daily a roster of patients who were admitted and eligible for pulmonary rehab. Then the patient hospitalist team and providers were informed about this, and patients also were contacted, and while the hospital were educated about importance of pulmonary rehab. So by this approach, we were able to systematically address multiple barriers in enhancing access to pulmonary rehab in patients who were recently hospitalized. And it's especially important in these patients because it was shown in multiple clinical trials that pulmonary rehab after admission really improves patient quality of life, improves their cardiorespiratory function and reduce readmissions. So we supported with this approach both referral, patient assessment, and help to complete program and enter into maintenance program. So the patients, as I mentioned, after they were identified, were given a tablet where they underwent pulmonary rehabilitation education to address the barrier of health literacy and to encourage patients to participate in pulmonary rehabilitation, and then help them to schedule post-discharge, initial post-discharge evaluation visit so that personalized pulmonary rehab program can be prescribed. So patients, while in the hospital, underwent this interactive curriculum, which helps them to be engaged and increase their interest in participating in this program. Once they were evaluated and this post-discharge visit was scheduled, the assessment was conducted remotely. Patients were assessed remotely in active range of motion. They performed sit-to-stand test, time up and go test, and dowel test, and arm bike test. This was done remotely so that we can really scale up patient assessment and address some issues with access to transportation and their time management, so it can improve their compliance and allow to replace 6 minutes walk distance test, which usually used by this battery of remote tests, so that physical therapist who did it was able to successfully prescribe, again, individualized program based on patient's specific performance parameters, so that the program was fully tailored to patients' aerobic capacity and potential limitations in mobility and other disabilities. So once the exercise is prescribed, the physical therapist was able to monitor patient performance. Alert system was set up so that if patients had any difficulties in following program or any components of the program, physical therapist was able to contact them. So this is an example of hybrid approach where there's in-person component, but then using the ongoing clinical decision support, patients are contacted only when they need help or for periodic assessments. And there's a flexible way to set up individuals alert based on each patient needs, adherence, and exercise program. The system also supported secure messaging between patients and the rehab team to continuously improve and support patients' participation and engagement. So based on this, we were fortunate to get funded by an HLBI grant where the core of this patient rehab unit included pulse oximeter, which is wirelessly connected to central service, internet connected, low cost portable bike. It could have included also activity monitors, and as a front end for patients, they could have used or a tablet or VR headset. So patients used a very simple interface. As a minimum, they were asked just to remember how to use this red button to start their exercise. And each screen was developed using iterative usability assessment and feedback from patients. Each screen provides only 1 or 2 steps, so it's very simple to move through this. It's self-explanatory and allows patients in very user-friendly way to go from exercise to exercise and really get interactive help, and supports also two-way communication with the rehab team. Patients are presented with a sequence of their prescribed exercise, and each exercise is explained by their Telerehab unit with scheduled instruction, precautions, and video explanation. And then when they start exercise, they follow their exercise and generate an exercise log. Their biking or cycling exercise is also prescribed. The trajectory is displayed on their Telerehab unit, and when they are biking, they are presented by the prescribed exercise or cycling trajectory and where they are, so that they can follow safely and efficiently to their personalized aerobic exercise. So they are helped to be engaged using a variety of scenery. The also system is capable of generating tailored feedback so that continuous engagement is supported. So overall, the pulmonary telerehabilitation system comprised of patient, home unit, and rehab team. And the rehab team supported comprehensive PT assessment, real-time support, tailored exercise program, and other components. So this was evaluated in randomized clinical trials. The main outcome was exercise capacity. As intervening variables, we analyzed motivation, self-efficacy, and other components. So exercise capacity was assessed using lower and upper limb stress, respiratory systems. We also analyzed behavioral underpinnings of drivers of how the system affects patient self-efficacy and motivation to exercise, quality of life, and urgent care utilization. Overall, 120 patients were randomized to intervention and control group. Intervention group was evaluated as I described and received personalized exercise prescription and Telerehab unit. Control group was what we call best available care. Control group also was evaluated and by physical therapists and received personalized exercise plan, but it was printed on a brochure, and we called it best available care. So the results showed a significant improvement in cardiorespiratory capacity assessed by 60-second sit-to-stand test. And we see here that during first 3 months, the improvement was shown in both groups because both groups were prescribed rehabilitation program. However, apparently participation went down in the control group, which resulted in significant decrease in overall improvement in sit-to-stand test as compared to intervention group, which continued improvement over 6 months. Similar results we found in upper extremity test and 30-second dowel test. We also showed that dyspnea was significantly improved in the intervention group. We found that COPD symptoms were significantly improved in the intervention group. The most important and exciting finding, which is relatively new to other studies, is our kind of mechanistic assessment of underpinnings of this model. We found that as in control group, COPD self-efficacy or belief of the patients that they can successfully participate in the rehab program will continuously going down in control patients where due to this ongoing feedback and support by Telerehab unit, COPD self-efficacy was continuously increasing in intervention group. The same results we received with another behavioral outcome, which is evaluates level of motivation to participate to exercise, and this definitely contributed to significant improvement in patient satisfaction with their rehab program, and also resulted in significant improvement in intervention group in their quality of life, specifically with physical functioning and fatigue, and also resulted in significant improvement or decrease in urgent care utilization in intervention group as compared to control group. We also found that overall there was a high acceptance of the Telerehab system, who reported that it's not using it not complicated at all. And the interesting result was that there was association between system usage and impact of web-based rehabilitation. So meaning that those who participated more showed higher improvement in quality of life. So it's always important to learn from patients about their perspective. And patients stated that doing the exercises with visuals helps them to focus on their breathing and how to do exercises. They thought it was good because it gives them more structure, what to do, and not just picking up a piece of paper. And they felt that the major benefit is that they felt that there was someone always helping them, and this was a person which provided them assistance online. So in conclusion, we felt that integrated IT tools have a great potential in improving referral and completion of pulmonary rehabilitation, and the patients who are engaged in this hybrid rehab program can experience significant clinical impact. Thank you very much. I really appreciate your attention.
With that, we're going to go ahead and thank you, Dr. Finkelstein. We're going to go ahead and pass it over to Dr. Smiley. Are you ready for your slides? And then again, if you have any other questions, please go ahead and put them in the chat and we can address them when we're done. I see there we go. All right, you're set to go. Thank you.
Thank you so much, Melanie. Thank you, Dr. Finkelstein, for your great presentation. Hi, everyone. My name is Smiley. I'm going to talk about the AI in telerehabilitation. And here is what I'm going to cover today. Briefly talking about what is telerehabilitation, what do we mean by AI in healthcare, how AI can support rehab at home, benefits and challenges of using AI, and examples from our own research, which we are doing at the Arizona Telemedicine Program, and what's going on next. And so let me start with a simple definition. Telerehabilitation is just rehabilitation that delivered at a distance. Instead of always coming into the clinic or hospital, the patient can do some or all of their rehab from home or another location. That could be a live video visit, a home exercise app, sometimes a virtual environment like the VR or the game that makes the exercise more engaging. But the key idea is we keep the core principle of rehab, including safety, progression, feedback, and human oversight. But we use technology to deliver them where the patient is. But why does it matter? There are several reasons. Many patients simply cannot attend regular in-person rehab. They may live far from the rehab center. Transportation can be difficult. They may depend on family members who have limited time off from work. We also saw during COVID that when the clinics shut down or reduced visits, rehab stops for many people. But even though their need for care didn't stop. So most of the people need ongoing support over months. Telerehabilitation is one way to make rehab more continuous, more flexible, and more accessible. Clinicians and patients frequently ask, does it really work and is it safe? Several systematic reviews have looked at telerehabilitation across conditions like a stroke and other chronic illnesses. Overall, the evidence shows that telerehab can achieve outcomes that are comparable to traditional in-person rehab. Interactive home-based rehab is promising for older adults. It can improve function and adherence while reducing the burden of travel. On the safety side, reviews generally show a good safety profile where programs are well designed. Well, by well designed, I mean clear instructions, appropriate screening, and some form of monitoring or checking. So at this point, telerehabilitation is not really experimental anymore. It's a viable alternative or complement to in-person rehab, especially when access to traditional services is limited. When researchers have studied AI in rehabilitation, they have found several common strengths. One is that AI can help personalize programs by learning what works for each individual over time. It also can help predict outcomes. For example, who might benefit from a certain type of intervention. It also can provide real-time adaptive feedback, such as correcting movement or adjusting exercise intensity. We also have AI-driven telerehab systems for stroke, MS, or other neurological conditions. In many studies, these systems have outcomes that are very similar to therapist supervised program. On the virtual reality side, like when the telerehab using virtual reality or VR for conditions like a stroke or Parkinson disease, the result often shows comparable or sometimes better motor and balanced outcome. So overall, combining virtual reality and AI is a new and very promising area, but we still need more standardized ways of measuring outcomes, stronger safety protocols, and longer term follow-up. Think of a telerehabilitation program as having several layers. At one layer, we collect data like movement, heart rate variability, analyzing the heart rate variability, symptoms, adherence to exercise. At the next layer, we analyze the data. Is the patient getting stronger? Are symptoms getting worse? Then we use that information to take action, like adjust the program, send the reminders, alert a clinician, or schedule a visit. AI mainly operates in those middle layers. It looks across all of the incoming data and learns patterns. This pattern usually means the patient is struggling. It flags unusual changes more quickly than a human could find it. So it can also suggest adjustment, like reduce the intensity today, or this patient may need a check-in call. And all of these nowadays mostly analyzed in the cloud AI. So in simple terms, AI is advanced pattern recognition. It's a software that learns from examples. It never replaces clinicians, but acts like a smart assistant. To do anything useful, AI needs data. In Telerehab, the main source of data we are using are the movements, like from the cameras, from the wearable motion sensors. We, as Dr. Finkelstein mentioned, we use vital signs, like measuring the heart rate, breathing rate, step count, sleep data. Also, we use self-reported symptoms like patients play very central role always. So they tell us about the pain, fatigue, mood, symptoms, shortness of breath, and or dizziness, the context that they do their exercise, time of the day, and environment. So these are all sources of the data that we use. So since I'm going to talk about some of the examples which are related to the data which was collected from the wearables and smart devices, I'm going to give a quick literature snapshot focusing on wearables and smart devices. So over the past 10 years, There has been an expansion of studies using smartwatches, activity trackers, and home sensors in rehab. Common findings are like wearables are generally feasible and acceptable. Many patients are willing to wear a device if it is comfortable and they understand the benefits. So continuous monitoring gives us a much richer picture than occasional clinical visits. We can see how patients behave on real life days and not just on the test days. And but the quality of the data is very important. The data quality can be the issue. People sometimes forget to charge the device, remove them, and sometimes they forget to wear the device. So AI comes in a way to make sense of this messy data. And instead of a clinician scrolling through thousands of data points, AI can summarize trends and highlight where something looks really a flag or worrisome. Here are some examples. Let me see how much time I have. Okay, um, so these are some basic examples. One of the powerful idea is AI acting as a coach for home exercise. Cameras or motion sensors capture how the patient is moving as they do their exercises. For example, lifting the arm, doing a squat, or pedaling a bike. Then AI compares those movements to the patterns that it has learned from many examples of correct performances. It can then give instant feedback to the patient, like lift your arm a bit higher, keep your back straight, or slow down. Therapists can review summaries instead of watching every session live. So when most of the people think of the wearables, that they think of step counts, but we can go beyond that. Modern devices like smartwatches, rings, chest strap can track heart rate and heart rate variability, activity intensity and duration, sleep timing and quality. AI models can then look for patterns such as poor exertion tolerance, for example, heart rate raising too fast for a given activity, sign of overtraining or fatigue, potential heart diseases, and so on. So instead of sending clinicians a huge raw data, AI can generate useful summaries and alerts for the clinician. Like there's a sudden decline in activity and sleep, and consider it checking and talking to the patients. Another role for the AI is as a digital assistant between visits. Think of a chatbot or voice assistant built into the rehab app. It can remind patients to do their exercise today. It can ask a few simple questions. How is your pain? Any dizziness with your exercise? It can help patients like symptoms in a structured way. For common questions, can I climb stairs, for example, the assistant can provide basic pre-approved guidance. If the assistant detects any red flags concerning symptoms or rapid worsening or repeated non-adherence, it can escalate it to the clinician. So virtual reality and a game like rehab can make exercise more engaging, especially when patients need to repeat similar movements for weeks or months. AI can monitor their performance in background and adapt the session. If they are struggling, it can slow down this or simplify the task. This is similar to how the human therapists adjust exercise in real time. Well, what is the benefits from the patient's perspective? perspective, what are the benefits of this? So one could be the convenience and access. They don't have to travel long distance. Consistency, because rehab can happen at home. It's often easier to integrate into daily routine, which improves the adherence. AI also can help tailor intensity, timing, and progression to the individuals. And immediate feedback, progress tracking, and game-like elements can make the process more motivating and less isolating. And for higher risk patients, remote monitoring of vital signs and symptoms can provide an extra layer of safety with alerts if needed. For clinicians, summary report, trend graphs, and alerts can save time for them. AI can help identify patients who are at risk, so the team can innovate more quickly and prioritize the task. Instead of relying on a snapshot assessment in clinic, clinicians can get continuous data from real-time settings. Over time, better adherence and earlier detection of problems may reduce hospitalizations. I also want to be clear about the AI, about what AI can do and what AI should not do. AI does not replace therapists, physicians, or nurses. It lacks the human judgment, empathy, and broader perspective that clinicians bring. It can miss important contexts like family support, depression, financial stress. AI is only as good as the data that you give it to them. So it was trained all with the data that you feed them. If the data are incomplete, biased, or noisy, the conclusion can be totally wrong. For those reasons, final decision should remain with humans. Despite the promise, there are challenges that we need to address. Not all the patients have reliable internet, as it was in one of the questions. If the devices or apps are confusing, patients will not use them. For the data privacy and security, these are sensitive health data and need to be handled carefully. For the regulations and reimbursement, we need clear guidelines. Which tools count as medical device? Who pays for them? How are clinicians reimbursed for the remote work? So these are the challenges that need to be addressed. Looking ahead, where do I see the field going? AI will get better at understanding each person's usual patterns and detecting meaningful changes. We will see more combinations of movement data, vital signs, symptoms, and maybe even a speech or facial expression analysis, giving a better view of the patient's status. In VR and AR, we will move beyond simple games to totally adaptive virtual coaches that can adjust exercises for each patient. The biggest shift will be from pilot projects and research study to routine clinical practice. Finally, I'm going to talk about some of the research examples that we do here at the Arizona Telemedicine program. We have multiple projects. We have lots of publications, journals, scientific conferences, patents, which were published. So one of the studies is making a smart bike, which I'm going to talk about it in the next slides, and using the sensors and AIs to estimate the exercise intensity while the patient engaging in the exercise. And another study is to applying the AI to predict the symptom escalation in people receiving chemotherapy. And finally, testing VR to reduce anxiety and pain in ICU. And finally, connecting all of this to the HAT system that Dr. Finkelstein was talking about. So for the smart cycling and home, we have one iBike system that was equipped with the sensors and microcontrollers. Here is the picture of the bike that we have. It has a small microcontroller inside the bike. This microcomputer can collect the speed of the bike and send it to the app which was designed and can be run on the tablet. So the data then everything would be wireless. So the data is going to be sent through the Bluetooth, and from the tablet, it's going to be wirelessly sent to the cloud system, and from the cloud system is going to be analyzed using the AI and also provide information for the clinicians. So the clinicians on the other side can monitor the real-time progress of the patient. So the game, we also made games for these bikes in both 2D and 3D. So the 2D version is on the tablet that the patients can play instead of the avatar in the game, and also the 3D version is in the Oculus Quest, the virtual reality system. So in one of the studies, we collected the physiological signals like the ECG pulse, oxygen saturation, pulse rate, oxygen saturation level, speed of the bike as a data, and then this data we give it to the AI models to train to see if they can estimate the exercise exertion level. And so we classified in the two groups of high exertion level and the low exertion level, and with accuracy more than 80%, we find that this AI tool can predict if the patient is in high or low exertion level. And the goal was to adjust exercise intensity in real time without constantly asking the patients. In another study, we got the data from the nursing school of in University of Utah. They had more than 26,000 days of data, which patients who went through the chemotherapy reported every day if they have any symptoms or not. And the idea was to use AI to see if we can predict by giving them like from 3 to 7 days prior days data, if we can predict if the patients would have escalation in the symptom and telling the nurses and doctors to be ready to get innervated and help those patients. So in another study, we used the virtual reality to improve the ICU experience. So after using the VR, those patients reported that their mood was improved and the anxiety and pain score decreased, and they had no serious side effects. Most patients tolerated VR well and find it very helpful. So bringing all of this together, our broader goal is to build a system for home telerehabilitation that connects different devices like the iBike, heart rate monitoring, and home sensor into the unified architecture. Uses AI to interpret continuous data streams and generate meaningful insights rather than raw numbers. Integrates with clinical workflows so clinicians can easily prescribe, monitor, and adjust rehab programs from a distance. Also, it supports patients and families with clear feedback, simple interfaces, and as little technical friction as possible. So instead of using the collecting data, physiological data by putting the device on the body of the patients and wearables, we wanted to make everything contactless. So by using the cameras and using the radars. And so everything, the patient doesn't need to put anything on the body, like straps or any devices or wearing any wearable devices. So I'm going to close with a few key messages. First, rehabilitation can bring high quality rehab into patients' home. It doesn't replace all in-person care, but it can greatly expand access and continuity. Secondly, AI is essentially advanced pattern recognition. In telerehab, it can personalize care, monitor safety, and help us spot problems early. And our own work, which I talk about, it was using the iBike cancer. I provided one example of the cancer symptom predictions and using virtual reality for ICU and making physiological measurements wirelessly. So that's all the ideas that are possible in these 2 days by using the AI. They are already being piloted and refined in real clinical settings. Finally, the future I hope for is one of the human-centered AI technology that respects privacy and equity, supports rather than replace clinicians, and ultimately helps patients and families navigate their rehab journey more safely. Thank you.